Hello everyone, my name is Sarah Azizian Amiri. I am a PhD researcher at Delft University of Technology, and it's my pleasure today to present you part of my PhD project, which goes on developing an electrosurgical knife integrated with a spectroscopy sensing system, which enables real-time tumor margin detection during the breast conserving surgery. Breast conserving surgery is the preferred surgical treatment for the women who are diagnosed with breast cancer in its earliest stage. In this type of surgery, instead of removing the whole breast, surgeons try to remove only the tumor tissue with some surrounded healthy tissue from breast of the patient, and the aim is to completely remove the tumor from the breast and meanwhile preserve the overall shape of the breast as much as possible. After the surgery, the pathologist investigates the excised specimen to see whether we have negative margin or positive margin as a result of the surgery. Positive margin indicates that some part of the tumor is still remained inside the breast of the patient and the surgery was not successful completely. And in case of detecting positive margin, extra treatment is needed for the patients, which could be followed by re-excision surgery to remove the remaining part of the tumor from breast of the patient. And this brings, of course, a lot of discomfort for the patient and also for the surgeons. The occurrence rate of the positive margin and re-excision surgery is still very high. And the reason is that in the surgical side, it's very challenging for the surgeon to discriminate tumor tissue from the healthy tissue and detect the border of the tumor clearly. Because these both tissue have a similar feeling and look. And that's why using an intraoperative margin assessment techniques becomes very handy in this type of surgery. By using such a technique, the surgeon can have a direct feedback over the tissue, which can lead to a negative margin and decreased rate of the positive margin and re-excision surgery. Among different type of margin assessment techniques, we are interested in diffuse reflectance spectroscopy or DRS. In DRS, an optical fiber, which is connected to the light source, emits the light to the tissue. This light travels inside the tissue. Some part of it might be scattered or absorbed by the elements, and then another optical fiber, which is in a short distance from the first optical fiber, collects the light and sends it to the spectrometer. And from there, we can have the data in the computer. In computer, from the raw spectroscopic data, based on the fact that each component has its own specific absorption and scattering in each wavelength, and by using an analytical model, we can understand what type of physiological parameters we have and what is the concentration of these parameters, such as blood content or fat content and water content. Here are some examples from diffuse reflectance of porcine muscle and adipose tissue. As you can see, we emit the light from 400 nanometer to 1600 nanometer. And in this table also you can see some of the main chromophores inside the tissue, such as blood, water and fat. And here are the main absorption peaks of these chromophores. As you can see, the spectra of these two tissues are quite different from each other. For instance, from 1000 to 1600 nanometer, we know that we have the main absorption peaks of the fat and water, and because the amount of fat and water in muscle tissue and adipose tissue are quite different, so the spectra in this area are different for these two types of tissues. And based on these things, we can understand what type of tissue we have, and we can discriminate this type of tissues from each other. Recently, researchers show that if we use DRS for breast tissue, we can discriminate healthy tissue from malignant tissue with a high sensitivity and specificity. And also they showed that the most powerful discriminative parameter for these two types of tissues is either fat-water ratio and collagen content of the tissues, or the measurements in a specific wavelengths, mostly in near-infrared parts. And based on this research, we now know that the DRS is a promising tumor margin assessment technique. But the question for us is that how to include DRS as a real-time margin assessment technique to the workflow of the breast conserving surgery. To do this, we decided to integrate an electrosurgical knife with DRS, and we called this device optical knife. We use electrosurgical knife because it's very common to use this kind of knife in breast conserving surgery to remove the tumor tissue and cut the tissue. And to integrate these two systems together, we put a metallic tube on the blade-shaped electrode of the electrosurgical knife, and as you can see in the picture, and we put optical fiber of the DRS system inside these metallic tubes. The optical fibers are connected to the DRS console, and the electrosurgical knife is connected to the electrosurgical unit. For further investigation of the effect of performance of this knife, we use porcine adipose tissue and muscle tissue to simulate breast healthy tissue and tumor tissue, because this two tissue has the same fat-water ratio as the target tissues, and fat-water ratio is the main discriminative factor for us to distinguish these two tissues from each other. After combining these two systems together, the first thing to consider for us was that when we use the electrosurgical knife, we burn the tissue, and this burning might affect the optical properties of the tissue. So the question is whether we can detect the type of the tissue after burning it with the electrosurgical or not. So the investigations showed that the burning increases the scattering of the light for the tissue, but the fat-water ratio of the tissue is hardly affected with the burning effect of the electrosurgical knife. And the reason is that the depth that light can travel inside the tissue is bigger than the depth of this burning area. So this burning would not affect the discrimination power of the optical knife. The other problem we had when we combined these two systems together was that when we use the electrosurgical knife, we'll produce a lot of heat, and this heat might affect the function of the optical fibers. For instance, you see an optical fiber in the middle, and we use this optical fiber in this setup, and we cut the tissue with this knife, and you see that some part of the optical fiber is burned. And also in the right, you can see a picture from the tip of the optical fiber before and after using it in this setup. After doing the electrosurgery, a layer of the debris forms on the tip of the optical fiber. We showed that this, as far as this is only a thin layer of debris, we can still detect the type of the tissue, but if we use the knife for a longer time, this thin layer becomes a thick layer and blocks the path of the light, and in this case the optical fiber loses its function. So we decided to have a new design for the knife, optical knife, in which that we protect the optical fiber from the heat produced during the electrosurgery, and for doing this we used quartz tube. And instead of putting the optical fibers directly inside the metallic tube, we first put the quartz tube and then the optical fibers. So the tip of the optical fibers is blocked with the quartz tube. And so that when we use this knife to cut the tissue, the optical fiber remains intact, and somehow the tip of the quartz tube remains clean. And the reason is due to the lower thermal conductivity of the quartz tube in comparison with the metallic tube. When we had this new design, we had also some questions to answer. First question for us was that when we have this quartz tube, and also when we use this design to cut the tissue, when we have the contamination on the quartz tube, whether we can still detect the type of tissue and whether this quartz-driven contamination would affect the tissue discrimination power of the optical knife. To answer this question, we design an experiment. In this experiment, we use an DRS probe, which is only a normal needle with 2 optical fibers without any quartz tube, to do some DRS measurement from porcine, muscle, and adipose tissue. And then we use the optical knife for doing same thing and taking some DRS measurement from porcine, muscle, and adipose tissue. Then we prepared 3 sets of optical knife and we cut porcine tissue with this knife, and this resulted in 3 sets of used or contaminated optical knife. And we used these 3 sets of knife to DRS measurements from porcine tissue and muscle tissue. So for conclusion, we had 1 DRS probe without quartz tube, 1 clean optical knife, and 3 sets of used optical knife, and we took DRS measurements with these knives from porcine, muscle, and adipose tissue separately. And for each tissue, we use 3 locations, and for each location we use 3 measurements. Then we calculate the fat fraction and fat photo ratio for these measurements, and as you can see, we didn't see any significant difference between the measurements of the measurements with the needle probe and the unused knife or clean optical knife. Also, we didn't see any difference between the measurements when we use the contaminated optical knife and the clean optical knife. And the thing we saw is that when, for example, if we look at the fat photo ratio of the muscle tissue, the fat photo ratio is for all the measurements still less than 0.4, and for adipose tissue is more than 5. And we can clearly see that there is still a big difference between the fat photo ratio of the muscle and adipose tissue, and we can still discriminate this type of tissue from each other. So we can conclude that using the quartz tube or the in presence of the contamination on tip of the quartz tube, we still can detect the tissue, and this won't affect the discrimination power of the optical knife. The other question we had regarding the optical knife was that whether we are able to do the cutting and DRS measurements simultaneously or not, or in the other word, are we able to cut through the tissue and meanwhile detect the tissue or not? To answer this question, we decided to go for a phantom study. Because with phantom, it's easy to adjust or have control over the fat photo ratio of the composition of the phantom, and also it's easy to form, for example, a layered phantom or form different shapes with this phantom material. So we simulated 3 different layers of the breast: adipose, fibroglandular, and tumor layer. Adipose layer has the most amount of fat, with 15% of fat, and the tumor layer has the lowest amount of fat with 20% of fat. Then we made a layered phantom for our experiment. The phantom has fibroglandular, tumor, and adipose mimicking layers from top to bottom. And to determine the performance of the optical knife during the cutting, we used the optical knife to cut through this layered phantom. And we control the movement of the knife with steps of 2 mm. So after cutting for 2 mm at each location, we kept the knife still and took 3 DRS measurements from that location. And after that, we had 12 points for this cutting process, and we calculate the fat fraction and fat photo ratio of each measurement in these 12 points, which resulted in the figures you can see here. By looking at these graphs, you can clearly see the transition from starting in the fibroglandular layer with 40% fat to the tumor tissue or layer with 20% of fat, and then to the adipose layer with the 50% of the fat, or this is also visible in the fat-water ratio of these measurements. And another interesting result is that we can also see whether the knife is close to the border of the tissue or not. For instance, when we have a fat fraction between the fat fraction of fibroglandular and tumor layer, we can understand that we are close to the border of these two layers. So in conclusion, we can say using the optical knife, not only we can detect the type of the tissue during the cutting, we can also understand whether the knife is close to the border of the tissues or not. And the last question we had regarding the optical knife was that how would be the performance of the knife in a realistic breast conserving surgery or setup. So we decided to investigate the effectiveness of the optical knife in detecting and removing of the tumors from a realistic breast phantom. Therefore, we developed a realistic breast phantom using the phantom materials we used in the last experiment. This phantom contains adipose mimicking layer, fibroglandular mimicking layer, and tumors in different shapes and sizes. And then we use these breast phantoms to perform a breast conserving surgery using the optical knife. But before the surgery, we took an X-ray scan from the breast phantom to find out the approximate size and position of the tumors. And as you can see in the pictures, a scan to make the tumors visible inside the breast phantom in X-ray images, we use barium sulfate as a contrast agent in the composition of the tumors. And then we perform a breast conserving surgery on the phantom using the optical knife, and whenever we were uncertain about the type of the tissue, we use DRS, and by looking at the measured fat-water ratio and the fat fraction, we could detect the type of the tissue and decide how to proceed. And after the surgery, we took again an X-ray scan from the breast phantom, and the black area you see here is the gap formed after removing the tumors from the breast phantom. And the tumors you can see, the removed tumors you can see here in a bright color. And by looking at this scan, we couldn't see any traces of the tumor material inside the breast after the surgery. So we can say for sure that using the optical knife, we can assure the complete tumor resection from the breast phantom. But of course, more elaboration is needed in here to confirm that the optical knife is ready for the clinical applications. And finally, in conclusion, we can say that when we combine the electrosurgical knife and DRS, the electrosurgery has no significant effect on this tissue discrimination power of the DRS or optical knife, as far as we use the fat-water ratio as the discriminative factor between tumor tissue and healthy tissue. And also, this combination enables the real-time detection of the tissue during the electrosurgery, and also we can understand whether the knife is close to the border of the tissue or not. And at the end, we can say that the optical knife or DRS integrated electrosurgical knife is a promising real-time tumor margin assessment technique which can be used during breast conserving surgery. For our future work, we are working on completing the design of the workflow for intraoperative application of the device, and we are going to test the performance of the device on a realistic setup in collaboration with the surgeons. And by acknowledging all these people, I would like to finish my presentation. And if you are interested to know more about this project, you are welcome to contact me. And thank you for your attention.